So, first of all, I must also be thankful too. Thank you for inviting me to see this wonderful part of the world. I don't think I would have had any other opportunity if I had not been invited. It's very beautiful. The weather is a little harsh, I think. I was familiar with the weather, but in England we do not have volcanoes, so it's a very special treat for me to see volcanoes. So I've been asked to talk about or address the question, is it right to normalize peritoneal dialysis dose? Now the short answer to the question I think has to be yes. It is important that we give the right amount of dialysis to compensate for the size of a patient. But I think it is more complicated than it may seem. And what I'll try and explain to you today is that we do need to think about this more carefully and perhaps adjust our guidelines to help clinicians make more sensible, practical decisions. So I'm going to cover a number of different issues outlined on this slide. Not necessarily in this order, but I will say something about the limitations of the dialysis dose model. We talk about both urea clearances and creatinine clearances and the different ways of normalizing those. And of course we'll discuss the minimum safe dose of dialysis treatment. But when we're talking about normalization in particular, I'll be discussing the difficulties associated with estimating the volume of distribution, the V in the KT over V, the problems associated with creatinine kinetics. They're not completely an answer to this solution. We'll also talk about ideal body composition and also account for what we call metabolic function, and does that need to be accounted for when we're thinking about dialysis dose. I'll then try to draw some conclusions. I want to start off by reminding us, everyone here, that of course dialysis is trying to do a lot of different things. We're trying to treat the uremic syndrome, and the uremic syndrome is a hugely complex thing. And we're really just talking about one small part of that, which is the removal of salt and water and small molecular weight molecules such as urea or creatinine or phosphate. But there are many other things which we have to remove with dialysis, which maybe normalization in this way doesn't make any sense. For example, toxins bound to proteins may not work in this way. Removing protein-bound toxins may not make any sense to normalize the dose for that. You have to do a different approach. I also wanted to make it clear that when we're talking about individualizing dialysis dose, that there are other factors that we're wanting to take into account. More important than anything, I think, for me, is that we are trying to support the different patients' lifestyle where possible. So we're thinking about all their different issues like work, family, travel, cognitive impairment, and we have different tools to do that with, for example, APD, CAPD, or hybrid therapies. But what I'm talking about today is really accounting for biological variability of the patient, and in particular the body size, in how we make that decision. So we're all familiar with the guidance of what dialysis dose we should be accepting as a minimum treatment. And this is a summary by the KDIGO organization of different guidelines around the country, including around the world, including Australia, Canada, Europe, US, and the Renal Association. And also, you could put in here the ISPD guidance too. And you can see here that the general consensus is that a minimum dialysis clearance that is necessary is a KT over V of 1.7, and anything above that, which might be part of residual kidney function, for example, is considered to be a bonus. You'll also notice that some of the guidelines include creatinine clearance in their guidance. And this is partly because of the difficulties associated with normalizing the KT over V, and it's partly important to remember that the best study that we have to tell us about dialysis dose, which is the ADIMEX study done in Mexico, in this part of the world, actually did, when it did its randomization, the randomization groups were to creatinine clearances and not to urea clearances. So actually the best evidence we have does actually relate as much to creatinine clearance as it does to KT/V for urea. So why was this sort of this minimum dose concept considered? Well, what I've done on this slide is to try and summarize all the studies that have looked, meaningful sized studies that have looked at the relationship of dialysis dose to survival. And what you see here is the first study that drew this to our attention, the Canusa study, showing a very clear relationship between dialysis dose, which is, or overall total dialysis dose, by the creatinine clearance or the KT/V for urea, against 2-year survival. And this strong relationship, you will remember, is present because of the presence of residual kidney function. So this is effectively a variability. This variability is all explained by residual kidney function and not the peritoneal clearance. Other studies that have looked at that is the randomized trial from Hong Kong. Better survival overall, but actually no clear relationship to clearances. There's the Adimex study randomizing to 2 different levels of clearance. Again, no significant difference in outcome. Here's the EPOS study. This is a European study in anuric APD patients. Again, really showing no differences associated with survival and clearances. And of course, there's also the Negasad group, which seemed to define a much worse outcome in really low levels of clearance, less than the KT/V of 1.5 or a clearance of 40. So the decision was made to make the line here. This is the minimum dose that you should be considering, and this is based upon what one would consider as the safe minimum that we so far know about. Of course, it's possible that patients may manage with a dialysis dose that is lower than that, but nobody knows the answer to that question because it's never been tested in a formal trial. So now we come to the problem of knowing whether your patient is fitting that target. And the problem here is that we have this difficulty in understanding whether we know what the true value for V is in patients on PD. Measuring clearances in PD is easy from the point of view of solute removal, because we can measure the solute in the laboratory, we know the volume of dialysate, you can measure the urea and the creatinine, that's very easy. The problem is in the estimation of V. And you can see in this study, which we did some years ago, this is in normal subjects, we compared the gold standard method of measuring V, which is the deuterium dilution volume, with other near subject measurements. Now you won't be able to see these different things, but we looked at a different number of measurements of estimating V. What you always find is these correlate together very well. So you get a correlation between 0.95 and 1 when you compare, for example, the Watson formula with the gold standard. The problem is not how well they correlate, it's how well they agree with each other. And to do that, you need to do a Bland-Altman calculation or plot. And you can see here that there are dots either side of the line between plus minus 5 liters in using the Chumley formula, using the Watson formula, where there's also a systematic error, using bioimpedance in this study, again, quite a lot of error, and also using skin fold thicknesses. So immediately I can tell you that all the measurements that we use at the bedside have got a systematic error associated with them when you come to measure the volume of distribution compared to the gold standard method. And this is another way of looking at that problem, but again it shows you that probably one of the reasons for that is actually biological variability. So not everybody in this room has exactly the same body composition. And even when we measure certain parts of it, so for example we can measure body fat using DEXA scanning, and we can measure total body water, which is this line here. This is now expressed as the percentage of body weight is total body water using deuterium again. You can still see that there's a lot of variability in these patients, or in these individuals. And this probably represents the true individual differences you get in any normal population. you simply cannot use an regression equation to precisely determine the body volume of water in a patient without absolutely measuring it. And this typically, again, is at 2 or 3 or 4 litres either way in terms of body composition. So first of all, there is a variability there which we can't really measure. Does using bioimpedance help this problem? Well, this is a couple of studies, one from Glenn Chertow in 1997 and a more recent study from Andrew Davenport in 2016. And you can see here, again, using a Bland-Altman plot, there's a huge variability in the prediction of volume from bioimpedance compared to the Watson formula in both of these studies. So again, up to 5 or even 10 kilograms in error associated with using those equations. So bioimpedance certainly doesn't tell you the same thing as these formulae. What about what it tells you compared to this gold standard method using deuterium? So we did this study in PD patients published in 2010, where we compared the standard method, that's the gold standard method, deuterium dilution, with bioimpedance, multi-frequency bioimpedance. And on this axis here, you can see the variability. So if everything was perfect, everything would be around 0. But what we're seeing here is a variation in the prediction in either direction, although a tendency for the bioimpedance to underestimate the body water in patients on dialysis treatment. And that underestimation was worst when the patients were overhydrated. So the more overhydrated a PD patient was, the more the Watson formula was underestimating the body water. And again, you can see this on here. So the black dots here are bioimpedance estimates. They all fall on the perfect line because bioimpedance uses a formula to link body weight as fat to body water, whereas when you measure the water absolutely correctly with the deuterium, you can see there are dots either side of this line, again with a tendency for there to be more water present in these overloaded patients compared to normal subjects. So I'm afraid to say that even in using bioimpedance, there is still some limitations in measuring body water. There's one other problem which we should also consider might be important. This is data from the HEMO study, so this is in hemodialysis patients, where they used estimated body water volumes from equations to compare that to the model urea volume in dialysis patients. And you probably can't see this so well, but typically the equations are overestimating water compared to the urea volumes. It may be that total body water is a rather imprecise measure of the volume of distribution of urea. So with all these problems with KT over V, maybe we should stop using KT over V in PD patients and just use the creatinine clearance. And there are some theoretically strong arguments for this. After all, we use that to estimate kidney function. We estimate that and then make it proportional to the body's surface area. And many bodily functions are expressed as a function of the body's surface area. The problems, however, are first of all that there's a differential effect of the removal of creatinine from the body when you're talking about residual kidney function versus membrane function. And as I shall show you in a minute, solute transport status has quite a strong effect on the creatinine removal. The other problem we have in these patients is they get progressive muscle wasting once they become anuric in particular. And so one of the premises related to measuring creatinine clearances becomes invalid. So first of all, looking at membrane function, this is data going back to the Canusa study many years ago. What you can see here is that the transport status of patients, low to high transport status, has no effect on the urea clearances that are achieved, but quite a strong and significant effect on the creatinine clearances achieved. So you can see here it's much easier to achieve a creatinine clearance in a high transport patient than it is in a low transport patient. And that's all fine and good, except for the problem that we also know in PD, which is that high solute transport is associated with worse outcomes, not better outcomes. So if we said you have to get a high creatinine clearance, and the only way you could do that is with being a high transport patient, the problem then is that we forget that high transport patients have worse outcomes. And this is data from Raj Malhotra and actually published in 2015 from, I think it's the DaVita database in the US, again showing that both for mortality, technique failure and hospitalization, high solute transport is associated with less good increases in risk of death, technique failure and hospitalization. So the problem then would be that we might bias ourselves in favor of achieving higher creatinine clearances once patients become anuric, and yet actually finding ourselves supporting therapy in the wrong group of patients. Those are actually going to have much more difficulty with staying on PD. This is to illustrate the problem of muscle wasting that you get in PD patients. So this is taken from a trial that we did some years ago, published last year, looking at the value of bioimpedance to help manage fluid status longitudinally in PD patients. This was a randomized trial, and I'm not going to go through the data in detail, but I wanted to show you some of the findings of this study because they are relevant to our discussion today. So here we see the changes longitudinally over time in body composition in both non-anuric and anuric patients recruited to this study. There were about 150 in each of these groups of patients. A lot of these patients came from China, but nevertheless what you see here is that body composition in non-anuric patients tends to remain pretty stable over time, certainly over a period of 12 months. But when you look at patients who are anuric, then you see these dramatic changes in body composition. You see a reduction in total body water happening here, and an increase in the extracellular water total body water ratio happening longitudinally. And the best explanation for this is that these patients are losing muscle mass. So when a patient becomes anuric on PD, they become progressively muscle wasted. Because they're becoming muscle wasted, their total body water falls because most of your water is sitting inside muscles. Because the total body water falls and the extracellular water remains the same, then the overhydration ratio gets worse. So the primary reason why patients become more hydrated with time on PD, according to bioimpedance, is this loss of muscle mass and an increase, or relative increase, in extracellular water. Why is this important? Well, the problem here is, of course, that if we're going to use creatinine clearances as our method of measuring clearances, and we're going to use that correct for body surface area, the assumption in that approach is that these measurements are only equivalent if the production of creatinine remains constant. That is the assumption of that approach. So if the creatinine production is dropping due to less muscle mass, then really what that's telling us is that we cannot use the body surface, the creatinine clearance for body surface area as a longitudinal guide to changes in adequate clearances. So should we be taking a totally different approach to normalizing the dialysis dose? Well, this is where I need to introduce you to the concept of allometry. So allometry is the study of biological scaling. And what I've shown here is a couple examples of the best known scaling relationships that have been observed in the biological world. So the first one, which is shown here, is the link between the weight or volume of a patient or person or animal and its relationship to the metabolic rate. And the reasons that that relationship being like this, with a log relationship but with a power to 0.67, is simply that volume to surface area ratios are not equal according to the size of an individual. So as a person gets bigger, the relationship of their volume to their surface area changes. And that's leading to this line here. There's also another relationship that's been described in the literature, which is called Kleiber's law. And this is a relationship between the volume of the metabolic rate to mass ratio. So you may remember, you may have seen pictures of small animals like mice have a much higher metabolic rate than an elephant, which is a very big animal. And this is still the case even within small people and large people. Smaller people have a different relationship between their metabolic rate to their body size. So it could be argued that actually you need to adjust your dialysis dose in relationship to not their clearances or their removal of clearance, but to their metabolic rate, because surely metabolic rate is the source of the productions of metabolic toxins that you're trying to remove. So does this apply to peritoneal dialysis patients? Well, there is a study which is trying to look at this. Again, it's from Ken Farrington and Andrew Davenport in the UK. And this is a little difficult to explain because of the way they did it. But what they essentially said was, let us imagine that all our patients have a KT/V of 1.7, and then calculate, because they know the V, calculate what the KT is in that situation. And then instead of dividing the KT over V, they divided the KT over different things like body surface area, or resting energy expenditure, or total energy expenditure. And that's what they've done here. And what you can see just about is that small people, less than 64 kilograms, compared to big people, higher than 80 kilograms, if you make this theoretical calculation, you can see that smaller people are getting a little bit less in the way of dialysis dose than larger people. In other words, it supports the idea that smaller people or smaller animals would need more dialysis to get the same amount of clearance once you start taking metabolic rate into account. So it's quite a small effect, but theoretically this could be possible. But I want to make it very clear that this is a theoretical study and not an empirical study. There is no data out there showing that, for example, patients who are smaller or have a higher metabolic rate are underdialyzed clinically. And in fact, when you think about it, there's no evidence, for example, that women do worse on PD than men. If anything, there's just a little bit of suggestion that they have a lower rate of technique failure. And there's also no evidence that patients who are more metabolically active have worse outcomes. In fact, in my experience, it's the opposite way around. The patients who are fit and metabolically active live longer and have better lives. It's the opposite type of patient, the patient who is sedentary, who is eating poorly, that worries me in the clinic. So although I think this is an interesting model, I think it is a theoretical one, and I do not really believe that it applies that strongly to PD patients. And one of the reasons for that might be that, of course, PD patients are a little more complicated than this. For example, we should take their calorie intake into account. The KT/V model does not consider calorie intake as part of its explanation for protein intake. And it may be that PD patients are surviving better because of the calorie intake they're taking, remembering, of course, that there are also calories from the dialysis fluid which are adding to that treatment regime. So I am a little bit skeptical about this, and I think it raises the question in one's mind as to how useful KT/V is in terms of a model that works for PD patients. It's only part of the story. Many years ago, I published this paper back in 1995, looking at the relationship between comorbidity, urea kinetics, and appetite and survival. It's actually an important study for me because it was one of my most cited studies for many years. And what this was looking at was that relationship. It found, of course, as we all now accept generally, that by far the most important predictor of survival on dialysis is comorbidity and age. That's the first important thing it showed. Secondly, it shows you that the urea kinetics really were not very good discriminators of those patients who would survive or not. There were much better discriminators in the study. So I'm just going to show you some of that data now. So these are the groups of patients. Those had no comorbidity, intermediate comorbidity or severe comorbidity. And of course, mortality was much the highest in this group of patients here. You can see that they did have slightly less KT/V and probably slightly less residual kidney function, but this was actually not statistically significant. The things that were really important and significantly different were their dietary protein intake, their calorie intake, dietary calorie intake, and also the total calorie intake. These were much more important factors. And what this seems to suggest to me is that essentially patients who have severe comorbidity have a much lower protein and calorie intake. Their urea removal is not so bad, so they must be catabolic. And the problem here is understanding, or how do you account for catabolism in patients who have renal failure, and how does the urea kinetic model really support that in terms of telling you what to do with dialysis dose? We did take this further, and we did a longitudinal study of patients who we had documented declining nutrition. So if you look at this group here, this is the mid-arm circumference declining over 12 months, and we then increased the dialysis dose here to see if we could stabilize their body composition. And you can in fact see that we did do that in this group of patients. By the way, they had a KT/V here of 1.4, and we increased it to 1.7. And here you can see we looked at a number of nutritional markers. This is albumin. You can see the albumin was falling in this group of patients. It actually continued to fall and then did start to rise after the intervention. But it only rose significantly in patients who had no comorbidity. So again, it may be that you increase the dialysis dose, you can improve the outcomes of your patients, but it's very difficult to do that when a patient is ill, sick, has multiple comorbidities, and is probably catabolic. So it's a complicated picture, and what we don't know really is how big a dialysis dose to give, and also how we normalize that dialysis dose. Should we normalize it to the body composition of healthy individuals up here, who obviously were had a better body weight and better muscle mass? Should we normalize it to their ideal body weight, or do we normalize it to their actual body weight? And we don't know the answer to that question. So we come back to the question, should we normalize it? Well, I think yes, bigger people must need more dialysis, so we have to make some accounting for the size of patients. But I do believe that clinical judgment and interpretation of the data is crucial, and we need to be able to recognize the limitations and the accuracy of what we're doing. One solution to this is not just to use your KT/V or your in isolation and just try and hit the target, but that you use this in combination with creatinine clearance as well, another way of measuring the dialysis dose, and also, of course, that you discuss this with your dietitian to look at the nutritional assessment. Just a couple of examples of what I mean by this. So here is a patient of mine, quite a big patient, as you can see. He has a KT/V of 1.57 and a creatinine clearance of 52 litres per body, per 1.73 meters squared per week. Should I increase the dialysis dose? I think most people I see in the audience say no. And I of course agree with you, because not only would we not be needing to that because the creatinine clearance is above the target, but also this is low because V is very big. And if I increase the dialysis dose, I must give them more glucose. You can only do that in PD. So what do? I put more glucose in and I make them fatter, which is the worst thing I can do. So when we talk about normalizing here, we need to think about the right way of normalizing the patient. Here is my second example. I think again you can guess what the problem is. The body composition is now the other way. This is actually a real patient of mine. She had a KT over V in the clinic of 2.4 and a creatinine clearance of 60 liters per week, and she's a high rapid transporter. Now, what I did was I asked my dietitian to help me calculate the KT over V if she had a normal body composition, because she was very, very thin. And when she did that for me, I recalculated the KT over V, and it was 1.6. So I thought maybe I should not reduce the dialysis dose, because maybe actually this person needs more clearance. She's also small, and you remember what I said about metabolic rate. She probably has a high metabolic rate as well. So I think, and she also has a fairly good creatinine clearance, partly because she's a high transporter. So she removes creatinine rather easily. So my conclusion was not to decrease the dialysis dose in this patient. And yet you can see very easily that the normalization here is a real problem. And hopefully I've helped you think about that for the future. So let me conclude. First of all, that despite no evidence that that increasing peritoneal dialysis dose improves survival, there is a general agreement in the literature that there is a minimum dialysis dose. And we have this concept of a minimum safe dose. In my view, in many ways, the urea kinetic model is flawed. For example, increasing dialysis dose does not automatically lead to improved clinical parameters such as nutrition. And I would remind you that there's good evidence that certainly in anuric patients there is progressive loss of muscle mass occurring in the PD population. By the way, this happens in hemo too. So don't think this is just going to be solved by putting everyone to hemodialysis. I have good data showing exactly the same problem in hemodialysis patients. Increasing the dialysis dose in response to these symptoms and weight loss can be beneficial. I've certainly seen that regularly in the clinic. In terms of symptom control, you can definitely see improvements. And I would always increase the dialysis dose if it has uremic symptoms that need benefit, even if the KT over V was above target. And finally, I would just remind us that limitations of small versus large solids must be recognized. And then, when individualizing the dialysis dose, the limitations of measurement must be recognized. So what I've shown you is that measuring the volume of distribution is difficult. At very best, you're measuring this within 10% either direction accuracy. So I think the guidance should not be a KT over V of 1.7, but a minimum KT over V of 1.6 to 1.8, according to your patient's body composition. But that's my view. Again, I've also shown you that creatinine clearance could be used, but you must remember it's affected by solute transport and muscle mass. My view is, as I've just said, I think a threshold single value for KT over your creatinine clearance makes very little sense in this concept. And hopefully we'll change this in the next set of guidelines. And my advice is that you use your clearances as just one tool in the aid to helping determine the optimum dialysis dose, bearing in mind many of other things, including body composition, nutritional assessment, uremic symptoms, phosphate management is also important probably, and also overall prognosis. If your patient is 88, does it really matter if they have a KT over V of 1.6? It's not going to change their lifespan. And if they're well, just let them be. Thank you for your attention.